Good afternoon. I'm Dr. Dale Bratzler. I'm the Chief Quality Officer here at OU Health and the university's Chief COVID Officer. I'm going to give a brief overview of where we're at with the COVID pandemic in Oklahoma as of today, and then spend some time talking about some of the new treatments that are available for COVID-19 and also highlight some of the things that have concerned me over the past week or so. So as of today, if you look at the national data sets, Oklahoma ranks 47th in the nation, 48th in the nation with respect to number of new cases per day. We're at 37 new cases per 100,000 population a day, and that's actually increased over the past few weeks, but the rest of the country has increased faster than Oklahoma has. So we've dropped to 48th, but we're having more cases per population. And of course, if you look at the national map, it's pretty easy to see where the big outbreaks are. Washington, D.C. has the highest rate of COVID-19 in the nation right now. New Jersey, the upper Northeast has been hit really hard. Illinois is being hit hard. Kansas still has a lot of cases of COVID right now, and we're starting to see more in Missouri. So again, I don't think we can be complacent at this point because we've seen COVID-19 migrate into Oklahoma before. According to the CDC, we're currently 42nd in the nation for new cases within the past week. So as of today, State Health Department reported 765 new cases, 31 more deaths, and the death rate remains right at 1.8%. Of those people who go get a positive test, about 1.8% of those people die from the disease. If you look at the trends, the 3-day rolling average is going up, as well as the 7-day rolling average. The 7-day rolling average today is 1,359 cases per day, and that 7-day trend is upward. And finally, one thing we've noticed here at OU Health and other systems around the state are noticing is that hospitalizations are up. There was a fairly large jump in the number of hospitalizations this week. As of today, there were 810 Oklahomans in the hospital, 236 in the intensive care unit. Just under a third of the people sick enough to be hospitalized with COVID-19 are in the intensive care unit. So again, as I've pointed out so many times before, we're going to continue to see deaths from COVID-19. And finally, when you look at the CDC's community transmission map, most of the state is now red again. We had seen some reductions in community transmission before. I think that with Omicron probably moving into Oklahoma more rapidly, we'll start to see more transmission, community-based transmission. So I want to spend a little bit of time talking about some of the things that have been topical in the past week. I think it may address some of the questions that have already come in, but just highlight a couple of things. And so let me just start with context. So as of yesterday there were 441,000 new cases of COVID-19 in the United States. That's the largest single day case number since the start of the pandemic. I think that's difficult to wrap our minds around when we remember where we were at 1 year ago, but more than any other day through the entire pandemic. We now know that Omicron is spreading very rapidly. I will highlight that, and I'll talk about it in just a moment, that we're not done with other variants at this point, and that rates of transmission of Omicron vary around the nation. So the Northeast, New York, New Jersey, those sites, 88 and 89% of all new cases are with the Omicron variant. That may not be the case in Oklahoma. I'm not sure we know at this point, but the incubation time for that particular variant is only 3 days. So when you're exposed to somebody who's infected with Omicron and you get infected, typically you'll start having symptoms very quickly within 3 days, and indeed you will start shedding the virus very quickly also. That's important when you think about the new CDC guidance for the general population on shortening the time frame for isolation and quarantine, because with Omicron, certainly you get infected fast, you shed virus very fast, and then that drops off over the next few days. And then finally, I think the other thing that really concerned me this week was the report both from the American Academy of Pediatrics and also the national news that 52% increase in childhood hospitalizations within the past week. And I would highlight that out of the Northeast, where they're seeing lots of kids in the hospital, they're virtually all unvaccinated. So again, parents, please think about getting your kids, if they're eligible, vaccinated against COVID-19. You certainly don't want your child to end up in the hospital. The handout I've sent out has a couple of graphics. One I highlight comes from the CDC, and that's that we're not done with the Delta variant yet. So we've heard a lot about Omicron potentially being less virulent, but there's still a lot of people in the United States being infected with the Delta variant, and we know that it has a doubling of the hospitalization rate compared to the original virus. Yesterday, CDC revised their estimates that Omicron accounts for 58.6% of all new cases in the United States. But again, we know in the Northeast that's more than 80 or 90% of the new cases. And so it's not evenly spread around the country yet. And I'm not sure we actually know what percentage of the new cases that we're seeing in Oklahoma are Delta versus Omicron. I'll be interested to see the weekly epidemiologic report today to see how many cases of Omicron have been identified. But again, when we see an individual patient, we don't know what variant they may be infected with. So that's very, very important. And I'm going to highlight when I talk about how we treat patients with COVID-19, because in the past, I honestly didn't care too much about which variant they had because the treatment didn't make a difference, but it does now. And so I want to highlight that as we go forward. And then finally, there have been a couple of papers this week, again, that have highlighted that the immunocompromised are really at substantial risk of both breakthrough infections, and if they have breakthrough infections, they have complications of COVID-19. So I put a graphic in that looks at breakthrough infections in immune dysfunction patients, and it shows that people who have had bone marrow transplants, solid organ transplants, rheumatoid arthritis, multiple sclerosis, HIV patients have much higher rates of breakthrough infections than people who are immunocompetent, don't have any immune dysfunction, and are fully vaccinated. So again, I want to highlight to think about that as you think about holiday gatherings, family gatherings, or anything else. If you're around people that fall into one of those high-risk categories, please be mindful of it, because they're much more likely to get infected if somebody in the group is infected. And a study in cancer patients this past week showed that fully vaccinated cancer patients, particularly those with blood malignancies, 65% of those patients were hospitalized, and 13% of them died if they got COVID-19. So again, think about the people you're around. It's part of our, what I would call, community obligation to be vaccinated. It's not about me, it's about who I could give the virus to in the community who may not be able to fight off the infection. So please think about that. So I want to spend just a moment talking about some of the new treatment options for COVID-19 in outpatients before they ever get to the hospital. And there's a lot of good news here that we have more tools that we can potentially use to reduce the rates of hospitalization and death from COVID-19. So the four categories that I'm going to mention include monoclonal antibodies. I'm going to talk about convalescent plasma. We pretty much quit using convalescent plasma in hospitalized patients because multiple studies showed that it did not have much impact on patient care, but I'll talk about it, that it may be useful in the outpatient setting. Remdesivir, a drug that we've been using for since the start of the pandemic, particularly in inpatients with COVID-19. There's now data that suggests it may be useful in outpatients. And then oral antiviral medications, new medications that have just been approved by the FDA. So let's talk about monoclonal antibodies first. There are 4 different monoclonal antibodies or combination antibodies that are on the market now. The original BAM, used to be called BAM, Bamlanivimab, that we used to use as monotherapy. In other words, you just got that one monoclonal antibody. We know that doesn't work anymore, but it's now marketed with another monoclonal antibody and has been very useful for the original variants and also the Delta variant. The second one, Regeneron's product, REGEN-COV, 2 monoclonal antibodies, which is approved both for treatment of patients with COVID-19, but also post-exposure prophylaxis. So if you know somebody who still tests negative, but they've been directly exposed to somebody who's infected, and they're high risk for the complications of the disease, we can go ahead and give them the REGEN-COV monoclonal antibody to protect them from getting the infection in the future. The new one, that's one of the newest ones, sotrovimab, it's not generally available in Oklahoma yet. I think it's just starting to come in. We expect to start receiving doses of it throughout the state. But this particular monoclonal antibody is useful for treatment. And then the last one is a new one from AstraZeneca called Evusheld. And this particular monoclonal antibody is approved for pre-exposure prophylaxis. It is only approved for pre-exposure prophylaxis, primarily in people who are highly immunocompromised, who the vaccine's just not going to work in, like a solid organ transplant patient. This particular monoclonal antibody we can give to the patient before they're even exposed, and it will give them up to 6 months of protection from future COVID-19 infections. So, just a couple of points about monoclonal antibody treatments. So the classic ones, BAM, Regeneron, we use those in people who have tested positive, usually not fully vaccinated people, who have high-risk diseases that put them at risk for complications of COVID-19. And we have to start those monoclonal antibodies within 10 days of the onset of symptoms. Once they're in the hospital, we almost never use them unless they came into the hospital for something else and we incidentally found out that they had COVID-19. They're approved for patients that are 12 years of age and over, and again, we limit them and we use them in patients who are at high risk of complications of COVID-19. I've already mentioned that Regeneron's product can be given to a high-risk individual who has direct contact with an infected person. Let's say a patient with diabetes or rheumatoid arthritis, their spouse gets infected. Their test is still negative, but we can go ahead and treat them potentially with Regeneron-COV to prevent future COVID infections, with one caveat that I'll highlight in just a moment. And then lastly, Evusheld, which is the new product from AstraZeneca. Again, it is not indicated for treatment. We don't use it post-exposure. It's only approved for pre-exposure prophylaxis in people who have moderate to severe immunocompromising conditions, who are on immunosuppressive drugs, who have cancer like leukemia or lymphoma, one of those, for whom vaccination against COVID-19 is just not likely to work. So I personally know solid organ transplant patients who have had 4 doses of the vaccine and still don't have any antibodies that can be detected. That's the person that will be a good candidate for this new monoclonal antibody, because by giving them this infusion, you can potentially prevent them from being, or this injection, you can prevent them from getting the infection over the next 6 months. So I go through all that. I know I feel like I'm giving a lecture here, but it's to get to the next table, which is really important and is driving a lot of conversations in Oklahoma amongst the healthcare systems. So look at the 3 monoclonal antibody cocktails that are available for treatment: BAM, REGEN-COV, and sotrovimab. The only one that's effective against Omicron is the sotrovimab. The 2 that we've been using, that we still have in our health system, are not expected to be effective against Omicron. And the challenge right now is, I don't know what percentage of the new cases in Oklahoma are due to Omicron versus still Delta, because those 2 products are effective for patients with Delta. We don't know at the individual patient level. And so when you're faced with a patient who comes in, who's tested positive, who has symptoms, who may be at high risk of complications, which one of the monoclonal antibodies do we give the patient? Right now we have BAM, we have Regeneron. we don't have sotrovimab, which is the one that is now in national short supply because it's being used for all the people, particularly in the East Coast and other places where we know that Omicron is a big deal. So again, we're having discussions in Oklahoma City right now amongst the health systems about is there a way we can figure out what percentage of the patients we see actually are infected with Omicron versus the original Delta variant, and that's very difficult to know without doing genetic sequencing, and you can't obviously get that done at this point on every patient. So that's monoclonal antibodies. The second one was a study that just came out, published from from Johns Hopkins, actually Johns Hopkins study, and they gave convalescent plasma, but they gave it to outpatients, people who tested positive within 7 days of the onset of symptoms. It's an infusion, obviously a plasma, and it was very effective, about 50% effective at preventing hospitalization. Again, we've largely stopped giving convalescent plasma in the hospital setting because it wasn't shown to be effective. But if you think about how you get COVID-19, at first it's principally viral replication that's causing your symptoms. And so if we can give plasma early, and particularly plasma that's high titer for antibodies against COVID-19, then it may be effective. The one thing about plasma is if you're in a community where Omicron is circulating and people recover from COVID-19, they're going to have anti-Omicron antibodies. So the plasma that you might get in that setting might be very effective against Omicron. So again, it's not widely used, it's not in the guidelines yet, but this study that's in peer review right now suggests that convalescent plasma for outpatients may be effective. The third one was a large study published in the New England Journal of Medicine that used remdesivir. Remdesivir is an antiviral medication that we've been using to treat in patients with COVID-19 for a long time. In this particular study, started within 7 days of the onset of symptoms, a 3-day course of remdesivir given in an outpatient setting resulted in an 87% reduction in hospitalization or death as compared to placebo infusions. Highly effective, on the order of the new antiviral oral medications. But one more tool that we have available, remdesivir is available. It is very expensive. It is not FDA approved yet for treatment of outpatients, and so an insurance company may not cover it. This particular drug is not paid for by the federal government versus monoclonal antibodies that are paid for by the federal government. So there are some real cost implications here, and it does require a 3-day infusion. In other words, you have to come in 3 days in a row to get the infusion. But potentially another tool that we may have to prevent the complications of COVID-19. And then lastly, the recent approval of the oral tablets, molnupiravir and Paxlovid. Molnupiravir is a drug that's used to treat mild to moderate COVID-19, patients high risk of progression. It can only be used in people 18 years of age and older, and is not to be used in pregnant patients because it could cause birth defects. It was 30% effective at reducing hospitalization and death when started within 5 days of the onset of symptoms. But the new drug that we're all waiting for, we're hoping it comes into the state fairly quickly, is Paxlovid. It's a protease inhibitor. You take it with another HIV drug called ritonavir, 3 tablets twice a day, 5 days. Needs to be started within 5 days of the onset of symptoms. 89% effective at preventing hospitalization and death. So again, used in high-risk patients who are at risk of progression to more severe disease. So again, I feel like I'm giving a bit of a lecture here on some of the drugs, but I just wanted to highlight that we're in a very different place now than we were a year ago, because we have new tools that we can use potentially to treat an outpatient, to keep them out of the hospital and potentially reduce death. And then the last thing I wanted to highlight was a very interesting study I read this week from the NIH. It was an autopsy study where they did autopsies on 44 people who had active COVID-19. And couple of things they found. One, the virus was found in multiple organs. It's not limited to the lungs. They definitely found it in the brain. And they found it up to 230 days after the onset of the infection. So it seems to be clear now that the long haul syndrome may be because the virus invades multiple organs and can last for a long time. So they pointed out our data proved that SARS-CoV-2, the virus that causes COVID-19, causes systemic infection and can persist in the body for months after you're infected. One more reason to not get COVID-19, one more reason to do whatever you can to get vaccinated and boosted to prevent it. And there were a couple of editorial comments that went along with this particular study that I found interesting, and they'll be on the handout, but I wanted to highlight this one that came from St. Louis VA Health System. Basically said, for a long time now, we've been scratching our heads and asking why long COVID-19 seems to affect so many organ systems. This paper sheds some light and may help explain why long COVID can occur even in people who had mild or asymptomatic disease, because they found the virus regardless of the severity of the illness. And then the second one was even more bothersome, from a biosecurity researcher at the University of New South Wales. We don't know yet the burden of chronic illness that may result in years to come. So we know that some viruses result in diseases that happen years later. Will we see young onset cardiac failure in survivors, or early onset dementia, because we know the virus gets into the brain? These are unanswered questions which call for a precautionary public health approach to mitigation of the spread of the virus. We need to stop spread of the virus, stop infections, because we don't know what the potential long-term consequences of being infected with SARS-CoV-2 will be for us. So those are some of the key things I've been watching this week, and I'm happy to answer questions.
Some based on what you just discussed. If on that national pediatric readmission jump you mentioned, is that also being seen in Oklahoma and or?
Yeah, so I looked at our children's numbers. We haven't seen a big increase in pediatric hospitalizations in our state yet. We have seen almost a doubling of COVID cases that are inpatient now, but not in our children's hospital. But I'm very cautious because I don't know yet whether Omicron is actually going through the Oklahoma population yet. And what they're finding on the East Coast, in these areas where there are a lot of pediatric admissions, is that they're unvaccinated kids. Vaccination seems to be highly protective for children. Unvaccinated kids are being admitted to the hospital. So remember, any child 5 years of age and older is eligible for the COVID-19 vaccine. Strongly encourage it.
And then you were talking about the hospital's ability, or which monoclonal antibody cocktail would work best. And so this person is asking, is the state's genomic sequencing shortcomings hindering our ability to know which one we would administer in Oklahoma?
Well, so I'm looking forward to seeing what comes out in the EPI report today to see how many of the new sequenced viruses are Omicron versus Delta. But I'm fairly convinced we probably are still seeing quite a bit of Delta, where the older monoclonal antibodies would be very effective. So as a clinician, when you see a patient and you have 5 days, 10 days or so to make a decision, I don't know what variant I'm dealing with. So we're talking about other ways that we might be able to get clues about which variant. So one of the ways would be if we're seeing in a community that the predominant new cases are Omicron, then using the old monoclonal antibodies probably doesn't make sense. We still have them. We could still use them. Sotrovimab, which is effective against, appears to be effective against all the variants, we just don't have enough of it yet. It is a national shortage. So we really need better information about circulating genetic variants of this virus to know how to go about treating patients. There is a test that can be done when you do a PCR on a certain platform. Our OU Health does have it, It requires another PCR to be done. But if you see something called the S gene dropout, which is a technical term where only 2 of the 3 genes that they test for are positive, if you see the S gene dropout, it's suggestive of Omicron. But that would require people to have an additional PCR before monoclonal antibodies, and then you would have to do it on this particular technology, which is widely available, but isn't the one that we use most commonly.
It's got a ton of questions here, so let's just kind of bam them out here. Should people consider canceling their New Year's Eve plans?
Well, you know, if you're fully vaccinated and boosted, again, I think you can do activities. Hopefully it's going to be, I know that New Year's Day is supposed to be really cold, but hopefully New Year's Eve, the weather will be nice. Maybe you can do things outdoors. I would try to limit the size of gatherings. Wear a mask if you're in indoor settings around a lot of people. And again, I highlighted, if you're around people who are at substantial risk of complications of this disease, be aware of that and do the courtesy of wearing a mask and preventing spread of the disease.
And what kind of masks are you recommending? Are there any different
Yeah, so we here at OU Health have made the decision, I believe we'll start next week. We're going to require everybody who comes into the system to use a medical grade mask, either a KN95 or a surgical mask like I'm wearing today. It needs to be good fitting, whatever you wear. It has to cover the nose. If it doesn't cover the nose, it does not work. There's some evidence that wearing a medical grade mask may be more protective than the cloth masks that many of us, including me, have worn for a long time. So we're switching.
Symptoms for Omicron are similar to regular cold flu, such as cough, fatigue, congestion, and runny nose. When should people get tested?
I think if you have any concerns at all, get tested. So the symptoms of Omicron tend to be congestion, runny nose, cold-like symptoms. Headache is prominent also with Omicron. But again, you can't tell the flu or RSV or para-influenza from COVID-19. So if you have symptoms, particularly if you are going to have to be around other people, please get a test done or do a rapid antigen test if you can find one.
And with those some of those symptoms being milder, do we still expect a spike in hospitalizations to continue?
Well, I think, as I highlighted when I started out putting things in context, 441,000 new cases. Even if this variant is milder, if you have that many cases, some percentage of them are going to end up in a hospital or have complications. And so, yes, we're still very concerned about spikes in hospitalization just by the sheer number of new cases of COVID-19.
So testing or reporting numbers are kind of conflicting. So between the CDC and what we've seen here, is there a concern that we're not seeing the accurate data on that?
I assume when you say, I don't know whether we're talking about variants, variant testing. Yeah, I mean, I think, you know, the problem for the clinician at the moment is the data isn't granular enough. If I knew in Oklahoma City, in our metro, that 90% of all the new COVID cases that were diagnosed in Oklahoma City were Omicron variant, then I would not recommend that we use the older monoclonal antibodies as a form of outpatient treatment. I just don't know what those percentages are. So that's the biggest challenge at the moment. We don't have data at the community level to be able to say what the circulating variants are.
How much of our high COVID death rate do you think is attributed to comorbidities in our populations versus public health policies, individuals' behavior?
Yeah, so the question is about, you know, Oklahoma's very high death rate. Many saw the study that came out from Johns Hopkins, their epidemiologist, that suggested Oklahoma had the highest death rate in the nation from COVID-19 per capita in 2021. Other estimates have ranged anywhere from 3rd to 11th, depends on what data source you're using, but the reality is Oklahoma has a very high death rate from COVID-19 per capita. So why is that? Well, I think it's two things. One, our low vaccination rate. We're just barely over 50% of our population is fully vaccinated. We have so many people in the community that are still at risk of the infection that may get infected. And then secondly, we do have a very high burden of chronic illness that puts you at increased risk of the complications of COVID-19, diabetes, obesity, lung disease, heart disease. Those are all prominent conditions in Oklahoma, puts our population at greater risk of death.
FDA said antigen tests may have reduced sensitivity to the Omicron variant. Do you suggest using them or get a PCR?
Well, I think, so the question is, should you use a rapid antigen test versus a PCR test? PCR test is still the gold standard, very sensitive, because it does something called amplification, which takes the specimen and amplifies any genetic material. So it's more likely to detect the genetic material of the COVID virus. But remember, the antigen test check for a protein that's found in the COVID virus that's quite prominent. There's a lot of it in the virus. And so it may not be as sensitive, but if you have a person who is symptomatic, you test them, they're negative, we suggest that they repeat it in 2 days, do it several days in a row, and you can get the sensitivity of an antigen test almost up to a PCR test if you do serial testing. So a single negative antigen test doesn't rule out COVID-19, but doing it several days in a row could.
I don't think you talked about the 5-day quarantine change, did you?
I really didn't today. I did have plenty of interviews about the 5-day change, but basically there are 3 points that I think are important. The first, if you're infected, you have a positive test. If on day 5 you're asymptomatic, you don't have to stay in isolation anymore, but it is strongly recommended that you continue to wear a mask for a full 10 days. And part of that's why I put that into context, that the infection occurs rapidly with Omicron, virus shedding happens early, and doesn't last that long. Is it a perfect policy? No, because some people will continue to shed the virus. That's why it only works if people actually stay in isolation in those first 5 days and actually continue to wear a mask for the full 10 days. If you're exposed, in the past we put you into quarantine for 14 days. Now that recommendation is that quarantine also lasts 5 days. They highly encourage you to get a test on day 5 and then continue to wear a mask. If you're fully vaccinated and boosted, you do not have to quarantine at all, but it's recommended that you wear a mask for 10 days anytime you're around other people. Again, none of these policies, none of them, isolation, quarantine, or masking, work if you don't actually do them.
Are there any reasons a doctor wouldn't recommend a booster?
Well, the only reason that I've ever had that we haven't elected to give a booster would be somebody that had a serious adverse reaction to the first doses. So if you got Pfizer or Moderna the first time around and you had a serious anaphylactic reaction, then we would be very cautious about recommending a booster dose. Or somebody that got Johnson & Johnson that had blood clots, I certainly wouldn't recommend another Johnson & Johnson vaccine. So it's primarily if a patient had complications from the first series of shots.
Do we know of data indicating any effect of higher body mass indexes on vaccine efficacy in men and women?
I haven't seen data on body mass index on vaccine efficacy, but we know that obesity is one of the leading predictors. Age and obesity are two of the strongest predictors of hospitalization of people who get infected with COVID-19. We know the virus can be found in adipose tissue. We also know now that the virus can be found in the brain and lungs and in multiple organs. So it's a predictor of hospitalization for sure. But in terms of efficacy, I don't know that I've seen any antibody efficacy studies.
And I think you touched on this, but do you have any thoughts on the report that we do have the highest death rate in the nation?
Well, so I saw the study. It came out of Johns Hopkins, their epidemiology department. They're obviously very, very good. I've talked to several. Part of the reason you see varying reports is what data sources are being used. Are they using death certificate data or the preliminary data that's reported by the state health departments and CDC, the provisional data? Are they looking at 2021, or are they looking at the entire death rate since the start of the pandemic? Because other states that had higher vaccination rates in 2021 when vaccines were available had lower death rates. Oklahoma, as we've already talked about, our vaccination rate isn't great, and so that puts us into a higher tier of eligible population that's susceptible for the complications of COVID-19.
Since at-home tests aren't going to get into official systems for contact tracing, how should a person with a positive at-home test proceed with letting others know they are sick?
Well, certainly, if a person does a home test and it comes back positive, they have to assume they are infected. They should go into isolation for 5 days, and then after that, wear a mask for another 5 days. And that's what the CDC guidance was yesterday. So, literally, if you test positive, you should not be around other people for 5 days because you are likely shedding the virus. It does not get into our state numbers, and I encourage people, if you get a rapid test that comes out positive, if you can go to a county health department, a health system, or others, get a PCR test just to confirm the test. But if you don't do that, you must assume you're infected. You must stay in isolation for 5 days.
Okay, that's it. Anything you want to add?
Happy New Year's to everybody. And again, I want to highlight, I've talked about this before, this is a public health issue. It's been so heavily politicized and so many different things that have happened this year. And it, profoundly affected, 800,000 deaths in our country, just unbelievable. So I just hope people will take it seriously, do what you can to protect your kids, your family, those that are immunosuppressed. Get the vaccine for them.